you're more likely to get a fake 1,000 shilling note than a fake 50 shilling note, because it doesn't make sense for you to go and fake the generic. Yeah, so the issue around counterfeits, and I know there is a lot of work going through the regulators, and when we are contracting providers, we make sure we are contracting providers who are known to have good reputation and who uphold good standards.
Hello, welcome to the One Health Lens podcast, where we have healthy conversations from health matters, public health, global health, and the road to universal health coverage. I'm your host, Dr. Diana Wangari Gitau.
And I am Dr. Simon Moshara Kigodu.
In this episode, we'll be talking about private medical insurance in Kenya. And as always, we have a very important guest who'll introduce himself. But I think many people have been wondering, what's the role of, I think, private medical insurance, especially with costs, premiums going up, right? The cost of healthcare is not coming down, apparently, right? So these are the conversations we'll be having. Most people have even asked, I've paid my premium. It should be a credit card. I swipe, I go to a facility. Why am I even asking for authorization? Why aren't they covering family planning? Why am I only getting dental and optical for 10,000? These are some of the questions we'll be answering today. Welcome, Doc. Can you introduce yourself?
Thanks a lot, Dr. So my name is Dr. Elijah Matolo. I'm the medical practice manager at All Mutual Health Insurance.
Okay. A bit of your background, because I've known you for quite a long time, yeah? What led you into insurance? Because Palvit is also establishing. There's a reason why you're here, right? There's what led you to insurance, working with insurance companies, when most doctors typically will say, insurance are not paying us, right? What led you to that?
Okay, so I am a doctor. That's my background. I also have a training in health economics. I decided to leave clinical practice because I wanted to go to where the real action is. So money is what moves the health system, and I feel that I'm contributing to making sure that there is enough funds flowing into the health system to get the healthcare services to wananchi.
Okay, perfect. So then the big money questions, we have the right guy. Yeah. Maybe let's start off with just how insurance works in this country, right? Just from a general definition and explanation, how does insurance work in Kenya?
Okay, so the insurance basic principles. So there's money that is paid by a policyholder or a member. This money is called a premium. On behalf, as a result, you get coverage. So you might pay something like 40,000 shillings, and then you'll be promised that you'll be covered for expenses up to 1 million shillings, assuming you got sick or you got hospitalized. Yeah, so those are the two things. So there's what you will get as your cover limit after paying a premium. Yes. Okay.
So what determines the 1 million versus 2 million? If, for example, I've paid the 40,000 premium, right? What's determining that my outpatient maximum I can spend on outpatient, and outpatient being me just walking in without being admitted, is 1 million versus some people who have outpatients for, 5 million, 10 million. What determines that?
Okay, so generally what determines the level of coverage is and the premiums is actuarial computations. So every insurance has an actuarial department that prices insurance products, including health insurance. So some of the factors that will go into the pricing will be the expected cost of care. And this is cost of care in various, aspects. So whether it is outpatient, it's how much does it cost for an outpatient visit, and how many times do you expect the population to visit hospital. And then if it's for inpatient, it's a question of what's the average cost of an episode of an admission, and how many people do you expect will be admitted in any given year. So based on that, then you'll get what is called the risk premium. Then now that is usually loaded with an expenses, so an administrative expenses to cater for the actual running of the schemes. And it's also loaded with business acquisition expenses and a small profit margin. Now, eventually what you get is a premium that a customer pays. So the limits will then be determined by other factors, including what's your age, the cost of healthcare increases with age. It also depends on where are you located. The healthcare tends to be more costly within urban centers. So if you have especially if you're doing pricing for a group, if you have most of your population within the urban centers, the premiums might be higher than if most of them are within rural areas. Other factors would include the choice of providers that you decide that you want. If you decide you want to go to every provider that is available, then the premiums might be higher than if you say you want to choose specific providers based on how they can be affordable. So generally then what goes into the pricing of premium will be the expected cost of care being the largest factor.
Okay. So then by the time I'm coming to, let's first start even with a group before we go to individual level. By the time I'm coming to you guys and I want to be covered, right? I've said I have this number of employees, right? Let's assume most of them are in Nairobi, for example. Since I know majority are female, there are certain things I'd want, right? So is it a shopping basket? Then I come to you and say, of my 100 employees, I'll want this. What happens so that then we get a scenario whereby someone say, one cover has, family planning, for example, covered, another one it's not covered. Yet, if you think about it, there are certain basics from a medical or even from a patient perspective. There are certain things when I have medical insurance I would want to have, but sometimes I don't get it. Whatever is in the basket, what determines that? Is it just the client saying, this is what I want and I can afford it? Or is there more?
So the group products are usually bespoke. That means that you're able to customize it based on what the client needs are. So you start off with what will be a standard product, and the standard product will include standard benefits. But if a client says, I need these extra benefits, then all those extra benefits can be included. Some can be included, without any price implication. Some might require you to pay some additional premium to get them included there. So if so then now the client becomes the one determining how that cover eventually looks like.
And this is also based on if they're willing now to pay the premium amount that it will end up being, right?
Yes. So the question around affordability and the budget available by the client then now determines what are the eventual benefits that will go into the cover.
Okay.
Yes.
So then we've had multiple cases, or people often say, right, that, okay, and you've mentioned this, there's the element of I can go to a certain doctor, a certain hospital, versus I can't go to another, right? Now, I could understand why that is, right? But most people say that, hey, I have a medical cover, and my nearest hospital, if it's Nairobi Hospital, I should go to Nairobi Hospital. What's the issue, right? What tends to be the problem? Why would one want to limit which provider they go to?
So it's a question of the expected cost of care. So we know that the cost of care would vary from one provider to another. So you'll find, so first of all, even within the same locality, depending on the level of the hospital. So a level 6 will almost always be more expensive than a level 4 hospital. That's because of the kind of patients that they tend to see, the level of equipment, the level of staffing that they have. Yeah, so depending on how and how you access care, then there's a question around, are you able to actually manage the cost of that? So, and one of the common things we'll always talk about will be, what is the average cost per visit? Yeah, being the basic inputs into the premium pricing. So if the average cost per visit in a hospital A is, let's say, 10,000, and the average cost per visit in hospital B is, let's say, 4,000, depending on which hospitals you decide you want to have, if more of the hospitals within the policy you take are the likes of hospital A, so then now that means your premium will be much higher than if the hospitals you are going to are the ones that have a lower cost per visit. Yeah, so that it's just that basic principle. So if at any point in time you're able to determine, and it's a question of, so do I think I can pay that higher premium? If you pay that higher premium, then you will have access to whichever hospital you want. But then now, if at the point where we were negotiating for the cover, we agreed that you would access these hospitals, then that means that if you went to these other ones, then that scheme would not actually will not be sustainable. You'll end up utilizing much more than what had been anticipated. So it's really a question of what is agreed in advance. And the good thing is that we ensure that there is quality in all the hospitals, so that even when there is an obvious difference in price, then the quality is not expected to be different.
Which then actually, and this is true also European Mr. Experience here, the question around accreditation of providers, right? There's always, first, you want to go to a certain facility or a certain doctor, and maybe you have a certain insurance policy, and you always have to call and ask that, do you accept XYZ, say UAP or Mutual, do you accept UAP? And if they say no, it becomes, am I willing to pay? Am I willing not to pay? Those are the questions you ask, right, as a patient, yeah? So then, what determines why Dr. Kigondo is part of your provider panel versus Dr. X is part? What determines that? Is it just application? What? Yeah.
Oh, okay. So so for purposes of managing the schemes, we enter into contracts with the medical service providers. Yeah, so the medical service providers, we will make sure that we have coverage in any region where our clients are present. Yeah, so that's the first thing. So we want to make sure that you have coverage anywhere your clients are present. You'd want to make sure, first of all, that the provider has the relevant approvals from either the regulatory bodies. You want to make sure that they are actually registered as a company, their documents are in order. You also look at aspects like tax compliance. Yeah, and then now after that, it's also what are your clients asking for. So most of the times you'll find our client requests are the ones that will determine which providers will be working with. Yeah, of course, there's also the question around capacity. So how many service providers are you also able to effectively enter into contracts with, and because there's also administrative effort from the insurance side in making sure that the contracts are running smoothly, payments are flowing as expected. Yeah, so there is always a limit into how many you can go into contracts with at any point in time. Yeah, but the good thing is that at any point in time, we always ensure that our clients are well covered. And in those rare instances where a client maybe is going to a doctor that we do not have a contract with, we provide avenues for them to pay and get reimbursed.
Dr. Kigondo.
Thank you very much, Matolo, for that very extensive explanation on what the insurance company is and what is. Of course, our issue is definitely at various levels is on empanelment, access to care, and sort of choice, sort of doctor's choice by the patient, so to speak. This has led to a lot of the interaction between insurers and healthcare providers to be a bit tense, so to speak. So in the long run, I think the ideal would be for health providers to actually be able to provide services to all insurance companies, and ideally that would probably, by virtue of having qualified, it is already some form of discrimination for an insurance company to say that Dr. X, a gynecology, who qualified at the same time as Dr. Y, can see insurance based on paperwork. And a lot of issues is paperwork, and we actually understand in the spirit of KYC is know your customer. It is also the effort of the provider to actually provide paperwork. But a lot of times it is not the provision of paperwork that is the problem. Is that, for instance, and I've been in the business long enough, and I've been in situations where the insurer says we are enough in your
You have
area,
enough
so to
doctors in that area.
but that does not take care of my patient who is covered by that particular insurer. So this is a question that we actually need to discuss, think around, because of course previous interactions have been almost adversarial, and they are directed at access, like what they are saying, you're making the client choose another particular doctor, yet you have a relationship with this. The second door is on, again, when you look at insurance as a cost, their cost, of course, they would like to have the least costs, to reimburse the least costs or not. But as part of their profit basis. But the bigger problem that we are having on that particular issue is that the insurer wants to look good by instructing that should the costs go beyond that particular service, then the client cannot pay. So it's almost they want to have their cake and eat it. So what do I say? For instance, if a procedure costs 100 shillings and the insurer has covered the patient for 80 shillings, the direction that the insurers are taking nowadays is to force you to take the 80 and do not allow you to charge the 20 to the patient, yet the cost is that. And that brings a little bit of friction on both sides. So the insurer will run to say that they have a contract with you. Yet we know that the cost may not necessarily be that, you see. So these are some of the issues that we would like the insurer to address, which are empanelment of basically for us who are in the rights, is that the patient should see any doctor and the doctor should be reimbursed, and the costing, I mean, there should not be some form of restriction, so that the provider is the one who makes the insurer look good. Yeah, so there are sort of some push and pull factors that we need to address. Maybe Matolo can comment on some of them.
He could, but I mean, and even to simplify what you've said, I think it's always that tussle between, and I empathize for the patient always when you show up to a provider who says, number one, I no longer accept insurance X, or even that initial tussle of I have to first call my doctor to confirm which insurance he accepts or not. all that, it's a lot of work, right? And I'm not asking you to bear the sin of the entire industry or the burden, maybe not the sin, but in that case, what, in your opinion, right? Because it's been a back and forth of providers, Dr. Kigondu, they want to be in the panel, right? We all qualified. Why should it be as such, right? Then there's that element of trying to, of course, you're a business, then in that case, you want to maintain your costs low, right? But then there's that push and pull between what's the actual cost versus what's going to be the forced costs, as the case might be, right? What's been your experience in terms of that engagement with providers, and why is it perhaps not feasible currently or might be feasible future?
Okay, so there are a couple of things which it's largely around how the system is organized.
Yes.
Yeah, so when you hear the discussion around insurance panels, most of the times it tends to be a very urban, town discussion. Yeah, because the moment you go out there, in the rural hospitals, you will never hear those discussions. Yeah, so it's a question of how the doctors have organized themselves, either in their own private practices. Yeah, so and a good example is if you're working within a hospital, the insurance and if all the aspects around the care have been defined. So number one, you're expecting the hospital is actually looking at what quality of care the patients are getting, but they're also looking at what the charges are eventually being levied on the patients or their insurers. Then all these discussions become almost irrelevant. The issue sometimes is that you'll find hospitals where, especially the issue around charges, there is no predictability. Yeah, so what one specialist will charge becomes very different from what the next specialist will charge. Yeah, so the insurance, we said we look at what, in coming up with premiums, there is the expected cost of care. So whenever what you're getting as a cost of care is not what you expected, then it has a negative impact on the sustainability of your schemes. So it becomes very important for there to be that predictability, where the hospitals, and some hospitals have worked towards getting that predictability, and if you ask them, they will not tell you that they've had any issues, where the hospital assumes a more, let me call it liberal approach, where doctors are at liberty to determine what their charges are, then it becomes difficult from the insurer's perspective to accept anything that will come out of that. Yeah, so part of the solution then becomes how then, number one, do we look at, so there's the aspect of quality, but then there's also the aspect around what is the cost of care, so that if you can have that predictability, then it becomes a bit easier. The other issue is that I think looking at some of the processes we have for claims, it's not a process you can manage when you're working with thousands and thousands of individual facilities. Yeah, so there's a question around, is it possible to have group practices? Is it possible to practice under an umbrella? An umbrella can be a hospital or it can be a group practice, and that will work. Yeah, anytime there are instances where maybe a member will go to a hospital, you'll find it's maybe someone, it's a specialist who has their own individual practice. Yeah, so it's not that it can't be solved, just that there needs to be creativity around how we solve that. How do we guarantee predictability of course, and how do we make sure that the administrative process around managing that, the entire process around claims becomes easier. Yeah, so I've also answered the question around what happens when the costs cannot be predicted. Yeah. So the insurance will have a set of charges that have been determined. Yeah, and this is what goes into your premium pricing. Yeah, so you do not expect that you will get charges that are above that, because then now it might lead to a problem with your sustainability. And I'm talking about sustainability because an insurance company will be sustainable only if the claims they are paying are less than the premiums they are collecting. Yeah, the moment you have the claims being more than the premiums, then you have the risk of having the insurance eventually not paying any claims at all. Yeah, and it's something that we should never allow. Yeah.
I mean, it's an important point. I know from a medical provider perspective, maybe there might be more empathy towards services, right? Provision of services. But fundamentally, an insurance company is a business, right? And as you're saying, you also want to limit your administrative costs. If you had to empanel all the doctors in the country, and then perhaps one only sees one patient in a year, there's a cost to that, right? So I can see where you're coming from. There's always, and we'll deal with the provider before you even go to the patient side, there's another question that tends to come up around quality of care. And this is usually around really claims, right? And I'll start off even with the pre-authorization process, right? Maybe just walking us through what pre-authorization is, because from a patient's perspective, I hate the fact that I have to go to a hospital and then the receptionist or the accounts person tells me, fill out this form, that's fine. I've either my fingerprint, whatever it is. And then they say, wait first, even before you see the doctor, we have to get authorization for this, right? So there's a certain limitation. Me as a patient, I'm not aware of perhaps. You might know for certain things, majority you don't know. Because then it adds an extra level of, in fact, it adds time, right? Because I'm waiting 30 minutes. Sometimes what I've had and I've seen as well is a case whereby someone needs to go for surgery. But then because of that pre-authorization process, it becomes, instead of you being admitted, say this morning, you first start the process the week before. So that when you get the pre-authorization is when now the hospital calls you and says, we've now gotten authorization, you can now come, right? So maybe just explain to us that pre-authorization process. What is it? Why is it necessary? Who's behind it? And not the insurance company, but who's doing the pre-authorization?
Okay, so the pre-authorization process is how the insurance provides approval for, and the approval is really providing a guarantee of payment. Yeah, so there are a couple of things that, first of all, that are verified is, so number one is the member currently covered. Yeah, because membership for usually changes. You might be covered today, then your cover lapses. Yeah, so that means when you come tomorrow, you're not on cover if the cover was not renewed. Yeah, so you need to check that. We said here that covers are bespoke. Yeah, so that means that what one person is covered for might be different from what the next person is covered for. So then now you need to verify whether the specific service being requested for is something that is within the patient's cover. But that tends to be for some specific uncommon services. The standards generally you not have that. The other bit would be there is an attempt to determine number one, what charges are expected. Because we say that there are hospitals where the pricing is liberal. Yeah, so then now that needs to be discussed in advance. Because the flip side is at the, if you're being hospitalized and that is not clear, at the end of the day, you do not want to find that, what has been charged is different from what was expected. And then the question around medical necessity. So pre-authorization is you usually have a team of clinical staff that will then be relying on what is acceptable, and here you're looking at the guidelines that you have available within the country, and sometimes you'll also make reference to some of the international guidelines. But the main part is really trying to look at that entire process, making sure that by the time you're giving approval for service, then you're not going to come later on and say that this is a service that wasn't covered. So pre-authorization tends to be a standard requirement for insurance schemes, and this is not just local. This is a global practice. The question is always around how then do you improve that process? How do you make it a bit simpler? There are aspects that can be automated. How do you even it's part of the challenge we have sometimes also. There's also a lot of variation in practice from one hospital to the next. So if there was some level of standardization, and you know that if I'm going in with this diagnosis, then the treatment is going to be the same regardless of the provider you've gone to, then some of these processes might actually be rendered irrelevant. So there's a lot that can be done around even how the pre-authorization process is done. To make sure that it is improved, make sure that it is led by evidence, which is what we always attempt to do, and make sure it's actually giving patients, because at that time it's a patient, you're giving patients the best outcomes.
And just speaking on that in terms of just improvement, Dr. Kigundu, because from what I'm hearing, from an insurance perspective, there's need for a lot of standardization, because that then makes it more predictable. That could aid in sort of bringing some of the costs down, right? So from, say, a medical association perspective, right, has there been deliberate efforts to then ensure that these are guidelines that then, say, insurance providers could lean on? And so then if someone is deviating from that guideline, it's a problem. Is it possible to do such a thing, or is it just left on the facility itself? Where does the association come in?
So there are various levels of guidelines, so to speak. And medicine is very similar and also very different at the same time. So one condition may look like it's the normal condition, but the argument by the clinician may be that, okay, there was this other aspect that came in, and that generally tends to be the situation where clinicians differ with insurance companies. So, for instance, you are going in for a straightforward cesarean section. I'll use that in my department, and then, there were additions, it took longer and all. So the discussion is, do you charge more? Do you charge more for that expertise or not? So that's usually the variance. The second one is that, of course, what has brought a lot of debate, there are fees that have been gazetted by the Kenya Medical Practitioners and Dentists Council as the fees that should be charged by physicians, and they give a range. And these were gazetted in 2016, I think. The insurer have their own fees also, which of course are less than those gazetted by
they cannot be more, for sure.
The board, you see. And that sort of tends to bring a variance, again, a bit of debate. So the question becomes, okay, so which fees do we use? And that, again, goes to that issue that we say is that, of course, the insurance companies want to look good in terms of their patient. What does that mean? If, for instance, the fees for a doctor is 50,000 and the insurance is offering 40,000, in my view, they should actually accept that the patient pays what is missing. But of course, in terms of image and generally clientele not wanting to pay out of pocket, then that leads to situation of negotiation. But generally, doctors are very good people when you negotiate with them. The biggest problem, I think, traditionally has been the speed of payment. You get, and the argument has been that first, you've been made to charge low. Then second, you're not paid on time. So there is not only the cost of that that has decreased, but the what we call the time value of money, which I must say that the insurance companies have actually upped their game in terms of turnaround time, in terms of payment. We must give it to them. And that, I think they also realize that also decreases fraud. You know, if you agree today to pay 3 shillings and you pay 3 today, then it's much easier than later when someone gives you an invoice of 10 shillings. Then you, who has taken too much time to pay, have to prove that it was not 10 shillings, but they've brought documentation. So already the speed at which services are paid for leads to a mellowing of both sides, so to speak, in terms of the costing. Maybe as we go forward, maybe some of these discussions are what need to come up with, because we have insurance companies that to date they owe doctors from a long time ago. But I think maybe Matolo can touch on it, what they have done over the years to improve the turnaround time of payment, because that has been the problem. People will give you a discount if they are sure money will come, but a lot of costs in insurance sector is as a result of you like have added for the time that it will take to get the payment. So those are the issues that need to be discussed: the board rates, additional pay by the client, and the turnaround time.
I tell you, you've been
yeah. So I think because the first point we mentioned was how do we standardize practice? So that's a very important aspect that would remove a lot of the unnecessary interactions that will be there, or we call it conflict. If
moments of tension.
Because and this is how all we will. I'm sure we'll evolve to that to that level. If you're looking at the UK system, where you have your NHS, and we know very well that this is what is provided for. If a patient has this condition, then this is how we usually treat. Of course, there's always room for exceptions, but they have to be exceptions. You cannot have then now everyone is an exception from the rest. So there is a majority who would fall within the guidelines, and there is always room made for that. I think the discussion around the charges, because the challenge with the medical board rates, as they are commonly referred to, is that they don't think they really consider the full picture around what the cost of care should be. Some of the rates that are proposed there, if we incorporated them into the pricing of our premiums, then insurance will actually be completely unreachable by a significant majority of the population. So there's need to really look at what is it that we can afford, and by we I mean us as the health insurers, but also the clients that we cover. If there is a way to make sure that at the end of the day that what is being charged is reasonable, then it also means that the premiums will also be reasonable. The premiums will always be a factor of the cost of care. When it comes to payments, I think the biggest challenge with the claims payment has always been how manual that process has always been. Yeah, by the time you're writing a piece of paper, and you're assuming you're in the opposite side of the country, by the time you're having it couriered to the insurance company, then the same insurance company is receiving thousands of similar claims from different parts of the country, then you can understand that paperwork actually it becomes very difficult to manage. So there's been a lot of effort to automate the claims process. And automating the claims process means that you reach that point where these days when you're going to withdraw money, you don't need to fill any paperwork. You actually don't even need to go to the bank anymore, and that's really what we are looking at. So right now, from the Old Mutual side, we no longer require our providers to send us physical documents for us to pay claims. So all that information is transmitted electronically. But process is still not yet very smooth, and part of it is because for you to have a smooth process, then there needs to be also still standardization. Standardization in how all the medical items have been have been named. So if you're looking at how a drug has been named, how a lab test has been named, because if provider A is naming it Panadol 500 and another one is saying this is Panadol 500 mg tablet, then when it comes into the computer, they look like they're two different things. And there's also the question around our making sure that even diagnosis. So diagnosis is part of the mandatory information before you process claims. And you'll find sometimes what people have been using is not what is acceptable. So there are several systems for diagnosis. There's been ICD-10 that we've been using. There's now ICD-11. So that if you write an abbreviation, that means that claim comes, but it can't go through the process. So that has been part of what has been done. There's still a lot more that needs to be done to make sure that the process then becomes smooth, so that by the time you lodge a claim, you can actually get your payment a few days later.
I mean, I applaud Old Mutual for doing away of that manual process, because I remember back in the day of coming with papers, then it's sent back. In fact, you'd have to get stamp, and then it was quite tedious. So that's good. But to this point around standardization, who needs to push, right? Is it the insurance regulatory authority? Because it sounds like a lot will be sorted out once they solve a standard process, right? Of saying that either this is how we name drugs, this is the protocol. Is it insurance regulatory authority? Is it medical authority? Has there been conversations where you've sat down, amongst insurance providers? Who do we turn to? Is there one voice or one, what do they call it, champion that then can guide this? Because then I'm assuming right now everyone is working on their own. Have you seen efforts around this?
Yes, so there's always been efforts, over the years to try and standardize, some of these things. So most health insurers work with technology partners. And they are a couple, so you'll find then each of them now ends up with their own system way of naming these procedures. But right now the Ministry of Health is actually doing a lot of work around defining these nomenclatures. So it's really just a question of at what point in time will they be rolled out into the market, and then it needs to be mandatory for everyone to adopt whatever has been agreed as the nomenclature that you're going to use for within healthcare. That then now makes sure it becomes easy, because even when you're looking at if you're looking at data, you want to make sure that these drugs or whatever services have been offered here, or whatever diagnosis has been mentioned, it is exactly the same across board, so that what one provider, one doctor is calling is different from what someone else is looking at. Yeah, so there's always been effort, even from the insurer side through our association, the Association of Kenya Insurers. Yeah, but you really want, you want the real big brother to come in.
Government.
Yeah, so I believe there's work going on around that, and we're just looking forward to jumping onto the bandwagon when the time is right.
Okay. I think with now UHC, the 4 healthcare bills having been enacted, and we're slowly, getting regulations and now implementation of social health insurance fund, right? Let's start off with just sort of what are your thoughts, right? Because there are different conversations happening, right? There's the conversation around contribution, which I think many of us do not have a say over what that contribution is going to be, or if there's going to be a cap. I know there are suggestions around there should be a cap and what have you. But I think the bigger question that most people have not heard of or hasn't been addressed is what's going to be covered, right? What are the benefits, right? What are the tariffs, right? Because I think this is what's going to also now affect where private insurance also is going to come and play, right? But in terms of just your thoughts and maybe what you're hearing, how will private insurance fit into sort of the new landscape of healthcare in Kenya? And I know you can't have a definitive response, but what are your hypotheses? If this happens, what happens?
So I think one of the good things that we are expecting is that there is going to be more money coming into the health system. So if there is more money coming in, then that means we can hire more health workers, we can improve our facilities, we can build more hospitals, and there is a general elevation of the health system performance. One of the challenges sometimes we have is the moment we leave the main cities, you get out of Nairobi, getting to see a specialist becomes very difficult. There are places where you only have 1 or 2 facilities. So then now if a particular specialized service is needed, then a patient actually has to travel, and that's extra cost. So it means that especially if a patient is critical, then that means you're paying for an ambulance to ferry them from whichever side of the country it is to bring them to any of the major towns. So we expect that to improve. If that improves, then we are going to be direct beneficiaries, because we work within the health system. One of the things that has been said is that there's going to be contribution from both the social health insurance for everyone in the country. So that means even our existing clients are expected to benefit. We don't know how exactly that would work, but if that is how it's going to be, then there's definitely going to be a benefit. And the benefit is that if there are services then that the Social Health Authority will take over, then that is potentially services that we will not need to cover. So that means it is either we will reduce the premiums, or we will be able to expand what we are currently not covering. I think part of the bills is also looking at how do you improve the capacity of public hospitals, through the facility improvement funds. As it is right now, we pay less than 0.5% of our claims to public hospitals. And these just tend to be the large national referral hospitals. There are a few county hospitals here that we're working with, but then now there's also our clients most of the times will not be going there. But if there is an improvement in services there, then it will also be of benefit to us, because then now there's a general expectation that even the cost of services would go down. So that means we can have lower premiums, or we can have more benefits being covered on our side. And then finally, I think it's also the question around how do you improve the digital aspects of healthcare? And I've mentioned the nomenclatures coming. There's the expectation of the health superhighway. So all those will have benefit to us. Yeah, sometimes a lot of extra costs are incurred because everyone keeps their health records in silos.
Yes.
Yeah, so that you're moving from one hospital to another, you have to start over again because that hospital does not have visibility on anything that was done previously. Yeah, so there are quite a number of benefits that are expected. Of course, on the contributions, the question is always, how will it impact the income of the organizations or the individuals that we are covering? Yeah, and will they see that this is a better option than what we are currently providing? Yeah, so they could go either way. Yeah.
Tell you, I mean, there are different thoughts in terms of it really depends on what comes out at the end of this year or as we go ahead with this journey, because if fundamentally I'm being deducted 2.75%, let's hope there's a cap, right? It makes for a very hard bargain to say then I also need to contribute for private medical insurance, right? But then there's also the question about quality. It's not just about contributions, right? It's also about the quality of care, right? Will I be able to present myself into a facility and I'll find a doctor or a specialist, right? So I can understand it's tricky as it is right now, but it's also a win for private insurance if then there's structures on the public healthcare system. It's a fact of where do you plug in, right? And how do you complement, as opposed to what has been almost like a competing what do you call it, relationship, right? I always imagine, right, and this is purely hypothetical, that then this will also allow for room for innovation, right? And by innovation, let me say specific to innovative products, not necessarily policy, right? Because, for example, I've seen different models whereby you present to the pharmacy, which of course had other issues. The different models whereby you must be seen by this provider before you go to the other, right? But then essentially it's always, I think, on the private side where there's more room for innovating, as opposed to government will say this is the way, fine, we get standard practice, fine. But then on a private healthcare and medical insurance, right, maybe you could touch on innovative ways or innovative trends that you're seeing in the market. Maybe it's something that you guys are also doing, right? It could be around, I've seen a lot also around women healthcare, cervical cancer, right? There's all this innovation. So then that becomes what do you call it, not a starting point, but it's a point whereby it remains as a role of private medical insurance, right? Are there innovative trends that you're seeing?
Yes, so there are a number. I think right now, and even what we now have as focus at Old Mutual is really to see how, number one, do we improve our coverage for preventive healthcare. Yeah, so we know prevention is better than cure, and there are quite a number of things that we are doing around that. So first of all is vaccination. How do we increase coverage of vaccines? So traditionally we only provided coverage for the vaccines that were listed under the Kenya Expanded Program for Immunization. But as we go along, we've realized that there's benefit for us providing coverage for more and more vaccines for our clients. Yeah, so we've also now moved, and we're not just doing it for children, we're also doing it for adults. So for adults who are at risk, that's maybe adults who are above the age of 65 years who are predisposed to quite a number of health conditions, and those with specific chronic conditions. We provide coverage for pneumococcal and influenza vaccine, and that helps because those are some of the conditions that actually become quite a burden for those specific groups. We're also quite keen to improve screening, and this is screening for especially non-communicable diseases. So how do you make sure if someone has hypertension, how do you make sure you're catching them before they ever get any complications? So we're providing comprehensive coverage for that. So screening for hypertension, diabetes. We're providing comprehensive screening for cancer. We've recently launched a partnership with one of the leading labs for coverage for HPV DNA testing, which is what is a gold standard for screening for cervical cancer. So there's a lot we're doing on that. I think the challenge we face is that back to the issue around guidelines, there are no clear guidelines around what it is that you should be screened for. So you've presented for screening, but what exactly should you be screened for? So there are isolated guidelines here. For cancer it is clear, but now for all these other things sometimes it becomes difficult. So that means you can get many things, or you can get very little, or you might get very many things, but they also leave out some critical elements around it. When you come to what we pay out for, so we pay quite a bit for outpatient care, and outpatient care will largely be treatment of respiratory infections, so patients who have colds and coughs. So we end up spending close to $500 million a year just doing that, and the challenge is because of that variation in practice from one provider to the next. You might find one is treating your cold at 10,000 shillings, another one is doing it at 1,000. So we are looking at innovative ways. We've provided access to telemedicine. Telemedicine does reduce the cost of care for specific conditions. So if you're if you have minor ailments, so we are providing that as an option. And for the clients who take it up, they realize a significant benefit. It saves on time, it saves you on cost, and it's also very convenient. You don't need to leave home to go and queue in a hospital for you to be given treatment for a cold. Just log on to your phone and you can get whatever medication your paracetamol brought to you at the comfort of your home. We also, and this is following in line with what the UK is doing. The UK has realized that there's a big role that pharmacies can play in the primary care. And we've adopted the same. And for some basic minor ailments, you can access over-the-counter treatment. And these are treatments that you are allowed to get anyway. It's just that now you're saying your insurance is facilitating that. Because if you went over-the-counter and asked for let me say cold cap, which is a common medication for colds, the pharmacy will give you, and it is within the law. So what we have been telling our clients is, yes, you can go, and instead of paying cash, we will cover the cost of that. And we've noticed that it's also helping in reducing that cost. If you reduce the cost of care, then there are two options there. So you either reduce the premiums that you're charging, or you're able to increase the benefits that you're providing. There's still so much that we are not yet able to cover, including the level of comprehensiveness for coverage, especially for chronic conditions. So one of the requests we've made to professional associations is there a way we can work together to moderate the cost of care, standardize, make sure. So quality will always be the first thing. So how can we achieve quality at a lower cost, and how do we then use the savings generated from that to provide coverage for some of the areas that are either not covered right now or are sometimes even neglected. Yeah.
I mean, it's not just, I think, there's a conversation around the supply side, which is where Kigondo comes in and moderating. But also imagine it's also demands you get from clients, right? Because I'd imagine you have clients who come in and say, we want everything underneath the sun. But at the same time, it doesn't maybe make medical sense, right? So what is the messaging around, or is that part of the guidelines you are alluding to? Because sometimes what we found, or not we found, we had a conversation just before you came in around weight loss, right? And the surgeon was saying that sometimes the request he gets, it's not even, there's no medical indication for it, right? I've just walked in because I know this person looks like this and this is what they did. This is the way I want. Yet there are certain parameters underneath it, right? So sometimes it's not just the provider, because then there are patients who come in and say there are certain drugs I won't, and they're not a medic, but they'll say, I will only take Augmentin, for example. I'll not take a generic drug. So is there education efforts? I think that's what I'm alluding to, education efforts, so that even patients are aware, right? So then it's not a burden just on the professionals. Educative and awareness initiatives, so that patients know, clients know. There's a reason why sometimes it's not always just to have Augmentin. You can take a generic as well. Do you have initiatives around that?
Yeah, so we're doing a lot of education around that, especially so when it comes to generics. The message from that we've been communicating to our clients is that they work just the same. Yeah, you know, if you've gone to the provider that you trust, then you know you cannot then say that this one is quality but this other one that they have is not. Yeah, because they've gone through their own quality processes to make sure that that one is done. That becomes one of the areas where there's a lot of inefficiency in our private healthcare system. And inefficiency is basically any instance where you're spending more than you should to get the same outcome. Then that one is already inefficiency. So how do we start reducing some of these inefficiencies? Generic utilization becomes one of them. Yeah, and we actively advocate for that among our members. For you know our patients right now, and by our I mean us as a health system, people read more. Yeah, so they'll be more enlightened than probably people were before, and it's purely because of the internet. They've made information readily available. Yeah, but so if a patient comes and demands for something because they saw it somewhere, I think our role as professionals, and now I'm referring to us as doctors, is to tell them this is what is recommended. Yeah, but you know, when you're saying this is what is recommended, you better be referring to a guideline somewhere, rather than what is your own professional judgment. Not that professional judgment is wrong, but when you have guidelines, then it becomes easy for some of these discussions, because guidelines are actually developed by the specialists themselves, and they've looked at evidence. And they've said this is what we know works. Yeah, so then now it helps some of those discussions, and it makes it easy to go through that. So if you're telling a patient you don't need an antibiotic, and you're giving them reasons, and when they go and look, hopefully the guidelines are available online. I googled today and realized South Africa has their guidelines available for members of the public to just look at. So assuming we had something similar, then the patients can go and say, oh yeah, my doctor was telling me the truth.
Yeah, true.
Yeah, so it also builds that credibility around you know, our the health system, that the professionals there know what they're doing, and they're actually doing the right thing.
As the One Health Lens podcast, we're willing to assist in education of your clients, just so you know.
We'd appreciate
it's important.
So I think also in terms of of course, there would be a lot of hula baloo in terms of the client going directly, for instance, to a pharmacy. The consultation fees are always a victim of the insurer.
Of the innovation.
But I think it's in good context, so to speak, because if I am a drug dealer, so to speak, selling drugs, so to speak, then there is the push factor. So someone comes and gives you stories, I'm feeling ABCD, then there is always that you see the pharmacy business would be to sell. So there is that danger, and when you now go beyond that, then when you have discussions around antimicrobial resistance and things like that, then also, and we have seen in our practice where there have been people on treatment at the pharmacy, then on the third week, when they come, then you find one, there was no examination, and there are conditions that ab initio, for instance, should have been surgical, let's say. Of course, the signs and symptoms would be amenable to one or two medications. So that's really the danger, but of course, point of care, sometimes for what they call minor illnesses, is there, but again, it becomes very tricky. What is minor, major? Because what sometimes is treated as a minor headache, so to speak, may turn out to be a bigger thing than it is. Yeah. In terms of generics and originals, so again, it's a pattern thing. I think we tend to throw the baby with the bathwater, saying some people are using originals, other generics. So generally what happens is, maybe again, it's a lack of standardization. If you buy from one pharmacy, the medication you may get is different from another pharmacy. You don't know their sources. So you may tend to get that the so-called generics may not work, but how sure are you it is not what do they call those fake drugs?
Substandard.
Not substandard.
Falsified.
Literally. I've forgotten the name, but fake, as in it's not what it is. Contraband. No, that's not the word. But yeah. So if so your client is not getting well, and the one who, so the client does not say the counterfeit. That's the word. The client does not say the drug was counterfeit. They say the doctor is counterfeit. You get, so to prevent such occurrences, then you use a drug that use a drug that you know will work. You get what I mean? Because you said, hey, I gave this one last week, this one, and hey, they didn't get better, and you're being called a counterfeit. You yourself, what may be termed up. So I think there are a lot of things probably would need research. You get, because maybe the war is not generic versus original. Maybe it's counterfeit. Maybe it's So some of these things are need to be discussed at that insurance level, so to speak. Of course, the original will be more expensive than the generic. But yeah, I agree. Their generics work, but there must be quality control.
I tell you, Matolo, we're inviting you again because there's now a conversation of generics, education. I tell you.
No, I think the question is really, when and this is an analogy given, if you are a counterfeiter and you wanted to counterfeit drugs, will you counterfeit the high value ones or will you counterfeit the low value ones?
The high value ones.
So that you're more likely to get a fake 1,000 shilling note than a fake 50 shilling note, because it makes sense for you to go and fake the generic. So the issue around counterfeits, and I know there is a lot of work going through the regulators, and when we are contracting providers, make sure we contracting providers who are known to have good reputation and who uphold good standards, so that you eliminate the risk that there is a risk of you getting substandard or falsified medicines. Yeah, but that discussion needs to be held. It's not that the branded medication is better quality than the generic. They actually expect it to be of the same quality. Yeah. So the branded might come with a fancier box. Yeah. But you see, now you're not consuming the box. The box is going to be thrown once you're done with the medication. Yeah, but it's really a question of how do we make sure our patients, and it's inefficiencies within the system. We are spending more than we should. That means, because there will never be enough money. We need to, whatever you're saving on that can always be directed elsewhere where there is much more benefit for us as a population.
I agree with you, because it comes down to education, but it's also this conversation around how to ensure healthcare doesn't become catastrophic expenditure, right? So that if I don't have private medical insurance, I am worried. If I don't have money, I'm worried, it's a conversation between beyond us in the room, right? Because it's not so much about private or public, right? It's fundamentally that if I'm sick, I should get that care where I need it, when I need it, quality care without, and what did they say? Without enduring financial hardship, right? And that's what UHC is about, But we're here to help you in education. And we're inviting you again to the One Health Lens podcast. Kigondo, right? You'll help with the guidelines.
So I think it's the insurance industry is an important industry, and both sides have the duty to support it and maintain it. We have had insurance companies collapsing, and they collapse with the money of providers, and therefore it's also in the interest of the providers to ensure sustainability of the same. So because it's better to eat for long than to eat once and die. You get, so I think
there you have it. There you have it. Thank you so much for joining the One Health Lens podcast. We'll see you next time.